Hello and welcome to the Airway Management topic in the Emergency Medicine module. By the end of this session, you should be able to define what is airway management, assess conditions prior to managing the airway, identify the airway adjuncts and its usage, and prepare and perform an airway intubation. Let's get started. Anticipating and recognizing respiratory decompensation is the only first step in emergency airway management. Practitioners must be familiar with the indications and techniques for airway intervention and how to anticipate a difficult airway. The basic approach includes assuring airway patency, protection from aspiration, and providing adequate oxygenation and ventilation. So, what is the initial assessment for the airway management? The initial airway assessment involves evaluating for airway obstruction or patency, which can be determined by assessing for snoring, stridor, drooling, hoarseness, edema, and facial trauma or burns. Patients who are speaking clearly without any distress or without any of these signs are unlikely to need an airway. Adequacy of the airway can be assessed initially by asking a patient simple questions such as what happened or what is your name. Breathing must also be assessed. Patients who are not properly ventilating and or oxygenating for any reason may require endotracheal intubation either in the short or long term. The most common cause of airway obstruction in breathing patients with a reduced level of consciousness is the tongue. The head-tail-chin lift maneuver, a maneuver that gently extends the head slightly into the sniffing position and lifts the tongue from the back of the throat, is the most reliable method of opening the airway when cervical spine injury is not suspected. So what are the airway adjuncts and its usage? A definitive airway is generally defined as a cuff tube placed below the glottis. However, a variety of airway devices and adjuncts are available to relieve or prevent upper airway obstruction. An oropharyngeal airway comes in a variety of adult and pediatric sizes and it's sized from the corner of the mouth to the earlobe. With the tongue blade to depress the tongue, the OPA is inserted over the tongue. Alternatively, the OPA can be placed upside down into the patient's mouth with the tip aimed at the soft palate and rotated 180 degrees. OPAs are contraindicated in patients with a gag reflex because they may cause vomiting and aspiration and are poorly tolerated. As for the NPA, like the OPA, can prevent upper airway obstruction. The NPA can be used in a conscious patient with an intact gag reflex and can be inserted bilaterally if necessary. The NPAs are measured from the nostril to the earlobe and are inserted in the bevel towards the nasal septum straight back along the floor of the nose until the flare rests against the nostril. Due to the risk of epistaxis or nasopharyngeal injury, NPAs are contraindicated in patients who are anticoagulated, have basilar skull fractures, nasal deformities or nasal infections, and pediatric patients. Next would be a back valve mask or BVM ventilation. Is the most important skill in basic airway management. It requires a good mask seal and patent airway. The presence of facial hair, absence of teeth, obesity, anatomic irregularities, and facial trauma are factors that can make BVM ventilation difficult. While providing BVM ventilation, extend the patient's head slightly using the head-tail-chin lift maneuver. If cervical spine injury is suspected, the modified jaw thrust technique is used instead. Place an OPA or NPA to assist with ventilations. The mask is held in place with the one-handed EC technique. Using the non-dominant hand, create a C shape with the thumb and index finger over the top of the mask and apply gentle downward pressure. Hook the remaining fingers around the mandible, taking care not to apply pressure to the soft tissues of the neck and lift it outwards towards the mask, creating the E. Endotracheal intubation is a critical, often life-saving procedure for severely ill or injured patients who cannot maintain adequate oxygenation, perform effective ventilation, or maintain a protected airway. Intubation is usually performed with a conventional laryngoscope, flexible fiber optic bronchoscope, or video laryngoscope. Proper airway management requires a thorough understanding of the indications of tracheal intubation, proper methods for endotracheal tube placement, and the pharmacology of sedative and neuromuscular blocking agents used in rapid sequence intubation. Now let's look at the indication for endotracheal intubation. The indications include failure of ventilation or oxygenation, obstruction, inability to maintain or protect the airway, potential for clinical deterioration, and delivery of treatment. As for the preparation of endotracheal intubation, the choice of ETT size is always a compromise between choosing the largest to maximize the flow and minimize airway resistance and the smallest size to minimize airway trauma. Next would be a syringe inflatable balloon, which is typically 5 to 10 mils. The distal tip is inflated after insertion, and the inflated balloon prevents air leaks to flow more effective ventilation and oxygenation while reducing the risk of aspiration. Then we have the malleable stylet. This should be used during intubation to provide shape and strength to the ETT. The stylet is inserted into the lumen of the ETT with the tip 1 to 2 centimeters from the distal end. And the laryngoscope. So it is a rigid instrument used to facilitate intubation of the trachea. The two main components are a cylindrical handle and the blade. The choice of the blade depends on personal preference and the patient's anatomy. Now, what is pre-oxygenation, which is done prior to intubation? Pre-oxygenation is an effective method to establish a pulmonary oxygen reservoir and thus prolong the time before hypoxia in non-breathing patients. 100% oxygen via face mask or non-rebreather mask should be provided to the patient prior to intubation. When pre-oxygenating using manual ventilations with the BVM, remember to squeeze the bag once every 5 seconds, delivering volumes just enough to cause the chest to rise. Gastric inflation can occur when the bag is squeezed too forcefully or too quickly. The ventilatory rate should not exceed 10 to 12 breaths per minute. Contraindications to bag path masks include severe facial trauma and airway obstruction. Now, when it comes to difficult airway assessment, it must be performed before attempting intubation, especially when using neuromuscular blocking agents. You can use the mnemonic lemon, which is a helpful tool to assess the likelihood of a patient having a difficult airway. L to look for signs of obesity, micronathia, evidence of previous head and neck surgery or eradication. E to evaluate the 3-3-2 rule. Normal mouth opening is 3 of the patient's finger breaths. Hypomental distance when measured should be at least 3 finger breaths, whereas the thyrohyoid distance should be at least 2 finger breaths. Then we have the Malambati classification, which is performed with the patient seated and neck extended. Open the patient's mouth fully. Class 1 is where the soft palate, uvula, fauces, and also the pillars are visible, and there's no difficulty. And contrary to that, class 4, where you're only able to see the hard palate, and this means there would be severe difficulty during intubation. O is obstruction, where there's evaluation for foreign bodies, stridor and other forms of sub- and supraglottic obstruction should be performed in every patient prior to laryngoscopy. And N, which is neck mobility. Patients with degenerative or rheumatoid arthritis may have limited neck motion, and this should be assessed to ensure the ability to adequately extend the neck during laryngoscopy and intubation. Let's take a look at rapid sequence intubation. Now I'll be showing you the formal steps of rapid sequence intubation. There would be a few important steps to remember, including plan, preparation, protect C-spine, positioning, pre-oxygenation, pre-treatment, paralysis and induction, placement with proof and post-intubation management. There are two essential components, which is induction and paralysis. Induction refers to creating an unresponsive state by the administration of a sedative such as etomidate or propofol, whereas paralysis refers to causing muscular relaxation by the administration of a paralytic agent such as succinylcholine or vecuronium or rocuronium. RSI maximizes the rate of successful intubation, decreases the risk of aspiration, and offers better C-spine control. When you're positioning, this refers to adequate positioning of the patient for successful intubation. This includes the head tilt, jaw thrust maneuver, as well as the burp, which is backward, upward, rearward pressure on the thyroid cartilage maneuver to position the trachea most appropriately to facilitate intubation. Once the patient is pre-oxygenated, sedated, and paralyzed, placement of the ETT is performed by introducing the blade into the right side of the mouth, sweeping the tongue to the left and lifting the tongue upward into the floor of the pharynx. Once a view of the larynx is obtained via laryngoscopy, the ETT is introduced with the dominant hand through the right side of the mouth. Directly observe the tip of the tube passing into the larynx using the vocal cords, such as the cuff passes the cords completely. The cuff is inflated and positive pressure ventilations are provided. The lungs are immediately auscultated bilaterally for equal breath sounds. Note the depth of insertion of the ETT at the lip line, and secure the tube in place. Once the ETT has passed through the vocal cords, the stylet is carefully removed and the distal balloon cuff inflated with a 5 to 10 ml syringe. A bag valve mask is attached and the patient is manually ventilated to assess breath sounds and lung compliance. Confirmation and proof of placement includes visualizing the tube passing through the vocal cords. Equal breath sounds should be auscultated bilaterally with an absence of breath sounds over the epigastric area in the adult. A post-intubation chest X-ray does not confirm the tube placement but will evaluate the depth of the ETT insertion in relation to the carina, left or more commonly right mainstem bronchus intubation, and complications such as pneumothorax. An orogastric tube is then often placed to decompress the stomach, and an arterial blood gas is typically obtained and evaluated. I would like also to introduce you to another airway adjunct, which is the laryngeal mask airway. It is seldom used, however, it could be important to recognize it and its uses. So conceptually, a supraglottic airway functions by occluding the esophagus and preferentially ventilating the trachea while establishing a seal in the upper airway or posterior pharynx to allow for positive pressure ventilation. The LMA is used as a rescue airway device to ventilate patients when traditional endotracheal intubation is not feasible. It is especially useful in cases in which the laryngoscopic view is limited by an inability to optimally position a patient's neck, as in cases of trauma. Difficult or failed bag valve ventilation and failed intubation are the most common reasons for using LMA in the emergency setting. So in summary, remember to understand and know the proper airway adjuncts that's available and its indications which leads to good airway management outcome. So we have come to the end of this session. Thank you for your time.